Well, one of the lessons I think that we learned from this is I've been around the region quite often talking to hospital administrators and administrators of some of your bosses about the role of the healthcare coalition and the work that we're trying to accomplish here. And what we routinely heard in a lot of cases was these things don't happen here. We don't have hurricanes. Very seldom do we have tornadoes of any great value. But I think this is evidence that things do happen here. They may not be the things that hit the news on the national level on a routine basis, but we routinely have things like power outages or water outages or plane crashes. Well, okay, I didn't say that. Bus crashes. Things that take place that impact the healthcare system, that the healthcare system needs to plan for. So this is just another example of that, and I like even sometimes the simplest lessons learned. Hey, somebody needs to check the batteries in the flashlight before the lights go out. It's always a good reminder. And come to think of it, I might do that when I get home. So with that, we'll move on to our next presenter, and this is really exciting to me because we've talked about what Providence has going on, and we've learned that they've been licensed for a new facility and that they're going to do some construction, and a lot of great things are going to happen. And now we get an opportunity to hear from Tamara, who is the Director of Psychiatry at Providence Sacred Heart Medical Center, to give us a little more information about that.
Well, hi. As I was introduced, I'm Tamara, and I'm going to give you probably a little bit more information than you want to know, but I think over the last 18 months, there's been a lot going on. When I was first asked to give this presentation, I thought, what the heck do I have to do with emergency preparedness, emergency response? And then as I thought about it, I thought, geez, the last 18 months has been nothing but responding to emergencies. Everything is urgent. Everything is a big ordeal because, for one, those who work in mental health, you know that we're actually already in a state of emergency. And then when you add on all the complications that happen that I'll discuss and the gaps in services that we have as no fault of anybody in our community, it's just a lack of resources and lack of funding. We're always in a state of emergency. I'll talk a little bit about, I'll give you an overview of what our organization is at Sacred Heart and what kind of services we provide. Some of the struggles over the last 18 months, which is, first of all, there's something called single bed certification, and there was a Supreme Court decision. And then 1 year ago and maybe 1 week, not that I'm keeping track, all of our psychiatrists resigned at Sacred Heart, and that kind of took up a lot of time over the last year. So it put us in the emergency mode. Oh, I've got too many things in my hands here. Switch. So Sacred Heart Medical Center is, we have inpatient departments. So we have an adult inpatient department that takes care of patients in need of inpatient psychiatric care of 18 years and older. And then we have a pediatric center for children and adolescents. We do only at this time take care of adolescents, which are 12 years to 18 years old. And then we actually, since we don't have a pediatric under 12-year-old program, we do have an outpatient program called Behavioral Education Skills Training. Some of you have heard of it. It's called BEST, and it is an intensive 5-week outpatient service. The schools refer these children, and we take care of them 6 hours a day, and there's a lot of family engagement to try to create a better way for them to cope better with some of the behaviors that they have. And then we have electroconvulsive therapy, and I want everybody to know it looks nothing like it does on TV. It is a it's actually a very good service. It helps a lot of people. And we actually we actually stay fairly busy because we're one of the only programs between Seattle and Minneapolis. And this sometimes is a last-ditch effort for people who need care for depressive disorders. We have emergency room, and it's usually very, very busy. I've seen Adam over there looking at the emergency room board, and I remember the day when there were only 20 patients waiting at this time of the day and not 61, which I just seen, waiting for services. So within the emergency room, we actually do have a separated space for 7 patients to be in a safe place away from the other patients. It was built specifically in mind for the mental health patient, and we keep some of our sickest patients there while we're waiting for an inpatient bed. And then we have what we call a psychiatric triage department, and this is a group of individuals who are stationed in the emergency room. They're mental health counselors, so they have degrees, bachelor's, master's in psychology, sociology, and social work, among others, and they actually provide risk assessments. So a patient may come in through on their own. They may be referred from Frontier Behavioral Health, may have a patient they want to bring into our location. We also may have police or ambulances bring them in, and our emergency room physicians count on these individuals to do the risk assessments, to say, are they safe to go home? What is a good disposition for them? Can they go home with a family member? Do they need further evaluation? So they're very busy, and we'll talk about the numbers here in a minute. And then we have the psychiatry consult service, and that is, we'll talk a lot about that one here in a minute, because that's a very big service that people often don't know existed within our hospital, but it is a vital service. So I thought about changing these numbers. They're 2000. See, I was originally supposed to give this presentation in November, like most of us, and didn't, and that's why I had the 2014 data. I did not change it to 2015 because we had a lot of changes happen in 2015 that wouldn't give it the full impact of what our services are and how much of a need there is in our community. So AGP is our adult unit. It has about 35 patients a day. We actually have the capacity to take care of 46, but that gives us the influx of when we have higher census, and then like most services in mental health, we actually have times of the year where we're under 35, so that's about what we have as an average in the past. Our adolescent unit has about 21 patients a day average in 2014, and that's with a 24-bed unit, and so they're just full all the time. Our BEST program does they take care of about 13 patients a day, and often there's a 4 to 6 week waiting list for our kids to get into the program. During the summer, the lull goes a little bit because, of course, they're referred by the schools, and kids aren't in school for the most part. But our wait list goes down, so that's good. ECT, we do about 6 patients a day. We're open 4 days a week. So it's really it's a service that's usually closed by noon, 1 o'clock every day. And then the Psych ED, that's that specialized area. We see about 230 patients a day. It stays full all the time, 24 hours a day. There's always another patient waiting to come into that area. And then our triage individuals do about 425 to 400 patient assessments a month within the adult ED, and 125 to 150 a month for the pediatrics. So just a very busy service line, have a lot going on. So I think one of the biggest things is to talk about what are the gaps. And like I said earlier, I think the gaps are much more. I have up there everything for everyone. I mean, I don't know if anybody really disagrees with that. Not that our community and our community partners haven't tried to give every service available, but there are gaps. And that's not just in Spokane. I mean, this is a national trend and a national issue. I think as a hospital focused, I think what I'd like the gaps in services that we see that keep people from moving to the next location is the really highly developmentally delayed or autistic patients who do not fit the need for or the ability to be admitted into our areas because they can't be a part of the programming. So there's a big gap there, and that's not necessarily a mental health gap. A lot of people think it's a mental health gap, but it's not necessarily a mental health gap. It's kind of a community social services gap. And then we have the elderly with dementia or Alzheimer's, and those patients, they have nowhere to go because if they have some behavior issues, violence, anything that goes along with danger to self or others, long-term care facilities don't want to care for them because they have other residents that they have to think of their safety for. So those are the patients. I mean, often for the elderly, we have patients in our hospital that stay 30, 60, 90 days. I think we have one right now that's, I think we're hitting 7 months. There's just no place for that person because they teeter between mental health issues and behavior issues, and there's just no safe place for discharge. And then just decreased resources over the years. I have not been in mental health services. I've been there 3 years. I've been told is we used to have a lot more inpatient beds and everything focused outpatient, and that's created a problem because we need inpatient beds. Not everybody can get care in the outpatient arena and get better. And then how many of you have heard of snipe hunting? Anybody snipe hunt? Well, you can tell I'm kind of like from the Midwest, Southern. Well, look it up on Google. So I was thinking today, the lack of providers kind of like snipe hunting, like you're looking for something that doesn't really exist. So we have a lack of psychiatrists, and everybody in mental health services know that. I think in general, we're going to have healthcare providers shortages everywhere. It's going to be physicians, it's going to be providers, and be nurses. And in our community, I know a lot of the mental health providers in our community are also struggling to maintain that level of position as well. So I thought I'd add a couple of things just for statistical purposes, just to make you think about it a little bit if you're not aware. So SAMHSA says that 1 in 5 adults have a diagnosable mental disorder. So don't look around. We don't want to stigmatize anybody. But I think the reason I say that is because at the bottom one, it says 2/3 of those with mental health diagnosis live very productive lives. So I think it's important to know that treatment does work. As they say, treatment improves the lives of 70 to 90% of the people. So we need to invest in mental health services and resources. Even though you can find pockets of where it may look like certain people or races or ethnicity have higher levels of mental illness, it really ultimately it affects everybody. And then it's 4 of the top 10 causes of disability. I thought those were pretty interesting stats, and certainly if they share the PowerPoint, all the references are in this PowerPoint presentation. I also thought it was kind of interesting to talk about what we spend per person, and in 2010, the Kaiser Family Foundation came out with this. They said U.S. approximately spends $120 per citizen for mental health services. Washington ranks 21st at 114, and the highest expenditure is $345 in Maine per person. So I don't know if that means Maine's a great place to be if you have mental health services, or a lot of people have mental health services or not. I don't know what that means, other than they do have the ability to spend more money on their resources. And then the last thing is just talk about psychosis, and such as major depressive disorder and schizophrenia are only second to the cardiac diagnosis. So I was thinking today, you know how many units we have in Sacred Heart that deal with cardiac needs? We have 4 units completely dedicated to cardiac needs, over 100, 120 beds, something like that. How many do we have at Sacred Heart? With 1, and it's 46 beds at its max capacity. So obviously we know that there is some needs to advocate and more resources. And then they have an inpatient hospital stay almost 2 times those who come in with heart disease. So just some neat diagnoses, or some information on the diagnosis of mental health. So because healthcare is very guilty of just throwing out terms, I thought I'd start with a couple of terms as I go forward. So voluntary, everybody kind of knows what voluntary, but in mental health it means someone is asking for help, and there's no need to force them to get help unless they change their mind and they need it. So Involuntary Treatment Act, or an ITA, that's where a patient who is 13 years or older is deemed by a mental health professional, which is someone who is trained, they're either a danger to themselves, others, or they're gravely disabled, just unable to care for themselves. A single bed certification is as a temporary designation of a psychiatric bed in a non-psychiatric unit. So often you'll hear this in the emergency room. We heard the word boarding. Everybody heard psychiatric boarding. A patient is in the emergency room. They're in need of care. They're being held against their will because they are mentally ill and sick and are a danger to themselves or others. But we don't have a bed to put them in. And so that's what single bed certification is, to say we're going to provide them treatment, which is usually medication management and so forth related to psychiatric services at our location. And then the boarding is just putting them in a bed that isn't, and this isn't just the emergency room, this happens for patients who come in for medical illnesses as well, and because they haven't cared for themselves, and then they need to do that. So I want to go to the kind of the first emergency. I have to tell you that nothing like a good emergency to get you like just immersed in what it's all about, I have to tell you. So it was right before summer, like 18 months ago, and I had this phone call of, we've got this Washington Supreme Court decision that says that we can't board patients anymore, basically. And I'm like, well, what does that mean? I don't know what that means. I quickly learned what that means. It means that it's illegal to put a patient, just hold them against their will without providing them some sort of service. And what was happening on the west side, this was a specific, you can certainly look it up, it was happening on the west side where there was patients who were sometimes in non-psychiatric beds waiting for weeks and weeks, and sometimes they would not even get medication management and so forth, which is not right. And we know that's not right, but it was, it's a symptom of the fact that we just don't have the beds that we need. And then the treatments varied. Sometimes they provided treatment and sometimes they did not. Sometimes it was very good treatment in some cases. So we thought, oh geez, this happened in August of 2007, and what do we do? Because we have patients who need to be held against their will because they are severely mentally ill, but we don't have a bed for them. So actually, you can do that. You can hold people against their will in a single bed cert if they have a medical illness, but not otherwise. This happened in August, effective December. We have all these patients throughout the state of Washington who are being fall in this category, and it puts a lot of legal risk on the hospitals. So really, actually, I would say not without our community partners, especially Frontier Behavioral Health, and now I want to say RSN, but BHO. We really inserted ourselves as a group into the West Side and started talking with Washington State Hospital Association and our Mental Health Division of Department of Health, and started reworking a single bed certification emergency rule. So we still met the criteria that the state law said we had to, but we were also meeting criteria for care of the patient. And that emergency rule became law. And so we do still have patients who are in emergency rooms or other beds throughout the city and throughout the Washington state, just depending on where you're at, who are waiting for inpatient psychiatric beds. I say this is an emergency because I have to tell you, the number of meetings I have is only second to the number of meetings I had. That's the next discussion I'm going to have. But it was just a lot of legal stuff. I mean, I never understood the legal system, and I certainly do now, and the importance of maintaining the civil rights of our patients, which brings me to our stakeholders were the Behavioral Health Organization, Frontier Behavioral Health, especially Frontier Behavioral Health has designated mental health providers who actually do the detainment, and this really affected their work as well. And we had all the emergency departments convene as well, because this isn't just Sacred Heart that's affected. This is every emergency room throughout our state who have patients come voluntarily, but actually are too sick to leave. Patients who are brought by the police or ambulances. And then I said we talked about we did the effective, the WAC was effective June 2015, the official one. So our goals was to maintain civil rights, provide appropriate care, and we really did, I believe, meet that. Some of these patients, they have to be cared for somewhere, and you can't release them to the streets. And actually, I'll say that Behavioral Health Organization and Frontier really put a lot of resources in place. Well, BHO supported them financially, and Frontier put a lot of resources in place to help all the hospitals within the city of Spokane help work through this process, because the patients not just show up in an ED and not have anything happen. So we had stabilized. It was like, woo, we've got a couple of months where nothing's happening. We thought everything was good. Well, you fast forward to May 2015, and we had 2 of our 8 psychiatrists resign, but one of them retired. They didn't really resign. One retired and one went to another organization. And then they started looking at the fact that we didn't have, remember I talked about snipe hunting, there was nobody else coming. We didn't have anybody coming to replace the people who were leaving, and they started looking at their call schedules, and their workloads were already really heavy. And they started, one would resign and said, I just can't do this, and the next one says, oh, geez, now there's only 6 of us, now there's only 5, and so within a number of 10 days, all of our psychiatrists resigned effective September 5th. So that was a really busy summer last summer. So, this was the initial reaction. So I have to tell you, it was like, what do we do? And this is actually kind of fun, because this is where I started thinking, in the spirit of emergency management, I found the stages of the disaster management cycle, and I thought, geez, we've gone through all those. So I've just aligned the rest of the presentation with those. really it's what the heck do we do? We're facing a lot of challenges here, and we have a community relying on us as an organization, and patients need help. So the first section is, we have the emergency. We know that we've got a lot on our plate, and Providence Health and Services just really stood up and said, this is what our mission is about. You can't really read, well, you may be able, it's pretty big here in comparison on my computer, but really our mission and core values came from the sisters. And the sisters, this was one of their primary groups of individuals to care for when they first started their work in Washington and Oregon. So we leaned in. We thought it was a priority for the sisters, it's a priority for us. I mean, we could have just said, you know what, this is too much work, this is gonna be hard, we don't know what to do, let's just forget it. And I think I'm very proud of the people I work with in the organization, because they didn't do that, because they knew that there was a community need, and it was just the right thing to do. It'd be easy to step back and just say, well, I guess somebody else is going to have to deal with it. It wouldn't have fixed the problem. But then the next question is, okay, we want to fix it. How do we fix it? So we went to the action plan as one of those next things you got to do, and they assigned us a project manager, and I've worked with this person in the past, and she's an expert in green belt, black belt, all those types of things. After this was all over with, she said, wow, this was the biggest project I ever learned, and wow, do I not have a bigger respect for the people who care for patients who have mental illness, because she was really, just as I have been over the last 3 years, inspired by the people we work with, the community members we work with, the staff who care for patients, and also knowing that it's all up to us to try to fix it, and it shouldn't be all up to us. We needed to make sure we engaged all the stockholders, and think about all the meetings you have that you think you have too many, and then add some to it. That was how many meetings we had, and in short term, when you have to meet next Tuesday, and you're meeting with the CE, and you're meeting with the chief medical officers, when are they available? 6 o'clock in the morning, 6 o'clock at night. So lots and lots of meetings and odd times and lots of long hours. So our response was, our top priority was really first, what do we got to do to re-recruit the physicians? To be honest, we did not know that there was this much discourse happening with the physicians and their workload. I will tell you, they did have very heavy workloads. Maintain as many services as possible. You've seen all the services we have. Well, they're all on the backbone of physicians. I mean, this is a physician model where we have physicians caring for all the patients. Prevent emergency diversions. I don't think we met that one, did we, Adam? We were always constantly working on that, but as our emergency room fills up with sometimes as many as 30 patients who have needs, mental health needs, and assessments and inpatient beds, it really leaves patients who need medical attention kind of on the back burner and waiting to get into an ED bed. One of the big things was this was rebuilding. This was not we're getting rid of it. So how do we keep over 200 staff working, not knowing what services we're going to provide? But we don't want to. We're in a union environment, and if you have to do any sort of a reorganization, it affects the entire hospital. And we didn't want to do that. We knew that this was just a short term. How do we fix this? We were hoping it was a short term. And as we went through, we knew that it was more, we could make it work. Involve our community, communicate. That was extremely important with our community partners. And then supporting our other people throughout the hospital who are now not normally caring for mental health patients, and now they're caring for them. And it's not a skill you just learn in nursing school. It's kind of one of those things you learn because you've been around it. On-the-job training. So that immediate response was weekly meetings with the physicians and just listening to them. What's going on, what's wrong, and what can we do? We really needed to build trust. Obviously, when this happened, there was not a trust there where people felt like they were listened to. And then we immediately lessened their workload. Shifted some, we had our outpatient department, the psychologists really stepped up and they took a lot of the work off the hands of the psychiatrists. Stuff like billing, they were doing their own billing. I don't know if this, they were doing their own billing, and then not only were they doing their own billing, but sometimes they would do their billing and then it would crash and they'd have to redo all their own building. So it was just those little things that were just really irritating, taking extra time. And then I will say that we worked on how are we going to get them decreased workload, because they were, I mean, it's hard to recruit when you say, hey, come work for us. You take care of 40 patients on the weekend and you work 12 days straight and you're on call too. So it wasn't really a great recruiting tool. And so we worked on how do we make it a better system for them. One of the first things we needed to make sure we maintained, and we did decrease workloads in the consult service for the physicians to bare minimum, just to keep the most ill patients who were not within the inpatient units they could be seen, and then maintain our inpatient units because they were really important. So when I said we'd talk a little bit more about the consult service, it's a vital hospital service. It goes everywhere within the hospital, except it doesn't need to go to the inpatient units because psychiatrists are caring for those patients. So they do medication adjustments and management. Somebody may come in with a cardiac issue and they're not acting quite right, and they have some meds they're on, and the physician who's caring for them, the cardiac, may say, I think we need to look at their medications to make sure it's right, they're taking their medication, so when I discharge them, they're safe. Risk containment assessments, sometimes our triage people in the emergency room, they're not quite sure, is this person safe to discharge, and they do need a physician to make that decision. And so they do that, and they also do that in the tower as well for patients who may have tried to commit suicide and they were unsuccessful, but they're in one of our beds because they were medically ill, and they need to have an assessment by a physician for next steps. They do legal requirement paperwork for court needs. They do some inpatient, outpatient services and capacity assessments. They also help support Holy Family at times for these same things. So you can see it's a really vital service, but it added 300 initial consults a month and 200 rounding. So you've got a physician on top of their workload. They're doing additional 12 to 15 rounds if it's one physician. And often because of the way we were set up, you only have 1 or 2 physicians on a day. So it's all on 1 or 2 physicians. And these are the locations, and I talked to just everywhere. They go anywhere that there's a question of a patient's mental capacity. So we had to figure out what they were doing. We had to figure out how are we going to continue this. And we turned to the people who were very excited about telehealth, and they've been begging to do more work. You know, it's one of those things we talk about it, but until an emergency comes, you don't deal with it. And so within 45 days for telepsychiatry, we chose a vendor, we signed a contract, we developed processes. I say we, it was a huge team effort. There's processes for them coming in the emergency room, there's processes for pediatrics, there's process for inpatients, there's process for everything you could think of where a patient could come in. There's different processes. So there were processes developed, and then we actually had to say, well, can we even support this technologically? So we had to do a lot of work in there. But I'm going to tell you, it was pretty lightning fast. We also had to credential and privilege psychiatrists, and that's usually like a 3-month process. It happens within 2 weeks when you really need it to. So that was good. We trained all the telepsychiatrists, mostly outpatient psychiatrists throughout the nation, who had to be trained on our program and actually just on our process because they're outpatient physician psychiatrists doing inpatient work. So that was a challenge all of its own. We could do a whole presentation on that, and it continues today. So we had to obtain staff volunteers and train staff to do different work because, as I said before, we had a union environment, and they don't have to do anything that's not within their job description. And so we had to get volunteers, we had to train them, and we had to educate the ED a lot and the pediatric hospitalists, and I'll have to talk a little more why we had to do the hospitalists so much. So telepsych went live. So this all happened, I think we said, 45 days, and we went live August 3rd. We used 9 to 12 hours Monday through Friday, 4 to 8 hours on the weekend. We are up to 80 hours a week, and it's not enough. So it's a program that we need. It keeps patients moving through our facility, but it just isn't. It's kind of one of those endless. We could have 90 hours. We could have 100 hours. It seems like we could always do something else because we aren't getting to see the patients every day that we're following. And then we actually implemented at Holy Family, so they have that support as well. It's actually probably a little bit more stable than it even was before with the psychiatrist. So I remember sitting at the table. I thought this was going to work out. I've become very optimistic. I'm like, they resigned, but they're going to stay. We're going to make this work out, right? And I remember right before the last week in August, so in May, we were like, well, we may not have beds, but I'm optimistic. I'm like, it's going to be fine. Right before 4th of July, we're sitting at a table and the psychiatrists aren't there, but we're talking about all these different plans, and came to realization we may have 0 beds. They may not stay. They haven't told us they're staying. You can't read them. They're not telling us. So we said, after 4th of July, you really got to say, are you intending to stay for a short time, even if it's 30 days? Are you going to, what are you willing to do so we can help plan, because it's coming fast. But I will tell you, that time when I sat there and I thought 0 beds, that was pretty overwhelming. And then I said, no, it's going to be fine. So on July 7th, we did confirm. I'll go back to one of those slides, because one of you might have seen the math that said 2 of the 8 resigned, that we kept 7 of the. Well, it's because we had a supplemental, so I wasn't counting the net, because some of you were OECD and could say your math's not right. So, but it was because I wasn't counting the supplemental in that. So in July, we did confirm that a majority of the physicians were going to stay, and that we would have 12 adolescent beds available and 12 adult beds. So we went from 46 adult beds to 12, and from 24 pediatric beds to 12. Pretty significant decrease. But the good thing is we were pretty excited just to have that, because when you're looking at 0, you're like, hey, something's better than nothing, right? So here's where we get creative. We're like, well, we got all these extra beds and we have all this staff. What are we going to do with this stuff? We have the ability. So we got special permission with the Department of Health to use some of our psychiatric licensed beds temporarily as medical beds. So we have our locked units. We have different sections of our locked units. And we had a whole complete section in the adult area and in the pediatric area that we could house patients that aren't psychiatric. They don't have a psychiatric physician as their attending. They have a hospitalist. So that was very unique. Again, a lot of meetings, because physicians who are not psychiatrists have only had, a month or 2 of training in mental health in their residency. They don't really feel very comfortable, prescribing medications and trying to manage patients. They don't understand their condition. So a lot of, again, now we added more meetings. We still have those meetings too, because there's always something new we get to learn from. Epic rebuilt. To do this, we had to completely rebuild part of our electronic health record. So that was done very fast in the world of Epic. It was actually done in about 30 days. And our telepsychiatrists manage all the risks and the medications within these areas. So they do an initial evaluation, and then every other day they round. And so, and then it's really a good environment, because instead of the emergency room, they're in an area where our staff are caring for them, and just doing the same routine things they would do with the patients who are in the locked area in the unlocked area. So I think, one of the biggest things was to say, we're keeping everybody working. The whole time, you got to imagine the whole time you have 200 staff members saying, what are we going to do? Worried about their jobs, worried about, a lot of them were actually worried about the patients. I mean, this is what's so great about working in mental health, is patients mean a lot to them. The people, they're passionate about their care, they're compassionate, they're there for a reason. And they were worried about themselves, but a lot of them were really worried about what are we going to do with the people who need our care. And so, we really just said, we kept telling them, we're going to keep you working. Whatever it took, we're going to keep you working. And we did. We had people volunteer. So in our world, you can volunteer to get time off, and you don't have to be paid for it. And then you have mandatory time off when you get to a point where nobody wants that. We did not have one person want to during this time. So that was a great accomplishment. And we just kept telling them, we're going to keep you working. That's because they all volunteered. We had so many volunteers to do some of the extra work that we'd asked them to do to help support our patients throughout the hospital, that it's very inspiring. And all these restrictions we had, we were able to make them work. It had to have the same scheduled hours, the same budgeted hours. They had to volunteer, but they still had to be within their scope of practice. So some of the things that we created to keep them working and supporting our patients who were outside of the psychiatric units was telepresenters. So the telepsychiatrists are on wheels, they're doc on wheels, and you have to roll them around. And we thought, what a great opportunity to have people, mental health counselors, who have this great skill. And most of them we had worked in the triage area, so they knew all the community resources, they knew assessments, they knew patients, because we have a lot of patients who keep coming through. So they would actually help the physician queue up the information. They go in with the patient. This still happens. They go in with the patient. They actually physically watch the patient and assess as the physician does his assessment. And then they leave and they go to a private area and they discuss that patient. And it really has increased our ability to provide good care, because there are gaps when you have doctor in a box. You know, you can only look at certain things, and our in-place people can help catch some of that, and they can help them, guide them with, these are our community resources, this is what we can do for them. And so it really has been successful, and we've continued. This is not a short-term solution. We really think that this is going to be continuing. I don't know, Jeremy, how long? Years. It really, right now, we're trying to fill our inpatient beds, physicians to fill the inpatient beds. So consulting service is something that will continue to be telepsychiatry for quite a while. So we actually have people now in place that is their full-time job. We have escorts. We have patients, you know, they needed to go one place to another. Court is a big reason. If they have the right to have their day in court, but in the inpatient units, we have a door that just adjoins and everything's locked. But in other areas, we'd have to escort them. So we had some of those, and luckily we didn't need that a lot, but we had people that did that. ED milieu managers, for those that don't know, milieu, they manage the area. So they cannot provide emergency room care, but they could be in the area where there may be up to 10 or 15 sometimes patients in a generalized area, and help the nursing staff in the emergency room redirect them and give them suggestions. So that worked out very well, and people really enjoyed that because it was just a different kind of job than what they're used to doing. And then we had people, we talked about single bed certs, and there's certain things, criteria you have to meet for charting and assessments, and we had people doing that because we had more patients in need of inpatient beds, so we had more single bed certifications. Other duties, whatever we could do to keep them busy, we kept them busy. And then the voluntary low census. And actually what's kind of funny is I ask for people to do volunteer jobs, and I get emails back, well, I'd like to take a voluntary low census every Thursday. And that's not the way it works. You kind of go in, and if you don't need it that day, you go home. But I'll be willing to take all kinds of time off. So, and I will say that we slowed down hiring for a very short time just because we were waiting. But we are full force hiring again. I have to tell you that between all of this, communication was the key. We didn't involve our community partners. I talked a lot with Frontier, and we have meetings with the emergency rooms throughout the community, and we continue to talk, and we talked with the behavioral health organization. I know that at one point, we've had a couple of these meetings where our chief executive and our chief medical officers bring together our, like Dorothy's been there, our meetings, our community meetings, just to kind of say, this is what's going on with this is the status. There were a lot of rumors running around, so. And we continue to have that. We engage Kootenai Behavioral Health because they take our kids that are under 12, but they also are a community partner in the fact that they are very in close proximity to us. And then all emergency medical responders, police, AMR. And then I think one of the things is and this is just more on, we ask for patience. That's what we asked for. Remember, please just help. And help us. If you have any good ideas, I'm sure there were some, but I don't think anybody just said, "Well, you're on your own," even though they were thinking that. Psych department communication. I always want to call this out because this was a great opportunity for my leadership to either prosper or fail. Because you have 200 people worried about their jobs, and even some of the leaders within the team are like, "What's going to happen?" I think they were more positive, like I was, but you still wonder what's going to happen. We really just communicated the heck out of what we knew, as much as we knew, what we're doing to help the physicians, where we're at with re-recruiting them, the jobs, the volunteer jobs. Just a lot of communication, because if you don't tell them what's going on, they make it up, and they still made some stuff up. So we pleaded their personal mission a lot. I mean, a lot of this, as I've said, over the last 3 years working in mental health, people are there for a reason. we have continued to struggle within our hospital of just trying to recruit nurses as fast as we can, and we're hiring them as fast as we can, but we have people specifically wanting to come to our service line to work within mental health, so that's just great news. But their mission is really a lot like Providence mission. We stayed encouraging and positive. I don't think there was one, other than that time when I sat there and thought, 0 beds, what are we going to do? I don't think I broke down once and thought negatively, but it was because I had faith that it was going to work out. Because just like the staff, the physicians, our psychiatrists really want to do what's right for our patients. And then just providing the message for the future. We also tried to have as much communication within the hospital, because this affected everybody within the hospital, on every unit in our organization. So recovery, I started thinking recovery, mitigation. We haven't recovered yet. We're still in the process. We were able to maintain our physicians. We did relieve their duties, some of their duties. We revamped their work schedule, put caps on the number of patients they care for. And they do get incentives for working extra hours, because some doctors, especially ones who come directly out of medical school, are more interested in extra hours than the people who are in their latter years. And recruit, and that's getting us, we are moving, but it's still a slow process because we're recruiting physicians who are still in school. So, sometimes we're still a year out. I think maintain the services, we've been able to do that. It's, like I said, it's no longer a short-term solution. It's evolving constantly. It's just a challenge. It's something new that nobody else has done. We do all of our initial consults within 24 hours. 1 or 2 gets missed, but I think that's pretty good for what we're doing, so patients can continue to move through the system or be discharged if they can. And then we continue to use overflow beds right now. So no issues with layoffs, and I'm going to shamelessly say, come join our team. I know not many of you are mental health providers, or if you are, you love where you're at, but I have to shamelessly plug. So the mitigation phase, it's just ongoing work right now. We meet with the psychiatrists and this administration, which we didn't have those meetings before. We talk to them, we find out what they're thinking, what their needs are, listen to their suggestions, find out what do you think is best. We do the same thing with the administrative meeting, and then we just recently had a community meeting. We'll continue to have those. So our optimistic future. We do have the residency program starts in July. The physicians get here, the psychiatrist, and then the residency psychiatry group get here in July. So in August, first week in August, we should have 6 more beds that are trained for psychiatry trained needs. We did sign 2 psychiatrists last year. They'll be arriving in September as soon as they should be out of school by now, something like that. So we're still determining what beds we're going to open with that, but that's a good sign because that will increase our inpatient capacity. We continue to recruit for the medical director and additional adult and pediatric. Pediatric psychiatrists are very, very hard to come by, and so we've had little luck in getting those positions filled, but we keep trying. I joined venture, but the joint venture with Fairfax, and I certainly can answer any questions you may have. I'll tell you pretty much what I know. It's going to be a 100-bed facility. That's kind of what I know. I think Alex Jackson always says you probably have 100 questions, and I have 2 answers. Really, it's a certificate of need got approved for them, Fairfax, to take care of patients who are under the age of 18 and over the age of 18. We will remain with some beds and services under 18 and over 18 at Sacred Heart as well. Other than that, there's a lot of work going on in the background with contracts that I don't know the name of it. I don't know exactly what patient population they'll take care of, but they will help close gaps, which also include outpatient services. Probably one of the biggest moving targets is the building they're going to move into is at 5th and Brown. And the people that are in that building cannot leave until September because a lot of them are residents and they have to wait for the WSU campus to get completed. And then that building has to be completely deconstructed because it's got asbestos everywhere. So very slow process. And then they have to build a 100-bed, I think I heard something like a $32 million building, $37 million, something like that building. So projected probably 2 years from now, something like that is when they will actually open. So light at the end of the tunnel for that. I mean, I think what our biggest goal right now is to open up more beds within our own hospital as the psychiatrists come so that we can help relieve, be a little bit of a pressure relief valve for the emergency rooms. And actually other organizations, we used to be able to take direct admits from other hospitals within the community and outside, and we haven't been able to do that since this all started because we have our emergency room and hospital are so full of patients and needs. So. And then Providence Health and Services came out and said our commitment for the next 10 years is mental health services, and they put some crazy number like $1 billion on it or $10 billion. It's a lot of money. And they're starting the gap analysis now of what do you have in your community, and they're doing that throughout all. There's 32 Providence Health and Services hospitals, and we are combining with another 20-some bed organization called St. Joseph's of Orange County. And so they're looking at all of those. It might be up to 50 hospitals and communities, and what do they have services, and how can we learn from them, and how can we build. So not a fix for tomorrow, but a fix is coming as we continue to infuse more resources and needs. And I know that Providence Sacred Heart and our local organizations really looking strongly at outpatient services sooner than later because there's a real need for that for the insured patient population. And I've talked a long time. So is there any questions? Yeah.
Dual view. Do you have dual problems with drug addiction at the same time? Is there any difference that you make? Because I mean, there's those who are just psychiatric, and then there's the more and more the psychiatric patients that also have drug problems. So are they all included in your numbers?
In my numbers we don't officially do any dual diagnosis care, but we do care for patients who have alcohol addiction, but we don't, we help them with their withdrawal symptoms, but we don't manage it any further than that. And those are in those numbers. I do know that that's something that is a need in our community, and I know that Fairfax is looking at that being one of the gaps in the area. So. And they have some really good programs on the west side.
Tamara, I know you said all you know is that there's going to be 100 beds in the new facility. Do you have any sense for the treatment of emergency patients presenting emergently, whether they'll go there or whether they'll go to your main ER first?
I know that there is a strong desire from our Chief Medical Officer, who's in charge of Providence Medical Group, a strong desire from Alex Jackson, our CE, to have an emergency room type of resource. I know they've mentioned it to Fairfax as they're building the contract. I'm not sure who's going to be doing that. You know, it's there's a lot of complicated things when you have it's not associated with on our campus with an ED. So, but I know that they're looking at that because they realize our emergency room is filled with patients who maybe just need crisis care, not necessarily need to sit in an emergency room. They're looking at everything we can do, and it's kind of, you know, one of the unfortunate things is this has had to happen for it to get a lot of attention at a lot of higher levels. So ultimately, it's really given mental health a higher level of importance within the organization than it would have been before when we were going along doing just fine and they're not hearing a lot going on. And then when something happens such as this, really says, well, what's going on over there? And they're like, wow, there's a lot of need here. So ultimately, it's going to be a good thing. It's just getting through it has been the biggest challenge. Okay.
Tamara, thank you very, very much. That was very informative and very a lot of information. And I think it just kind of replicates what we see a lot in our region, just the ingenuity and the ability to overcome situations and the way that we work together and pull a community together to solve a problem. Really a lot of great work that they did to get through this situation and to prepare for the future of where, to help meet the gap in the needs that we have. So thank you for that. We're going to take just a quick stand-up stretch break, but before we do, so imagine you've been sitting on your couch at home for an hour watching TV, and all of a sudden you need a break. And what happens when you take a break on TV? You get a commercial. So I'm going to give you an unsolicited commercial just so that you can have an opportunity to feel like you're at home. Yesterday I was at a meeting in Spokane. I got out a little early, so I spent my lunchtime. I drove over to the blood bank, and I donated blood. And I learned something, or was reminded of something that I knew, but I want to remind all of us the same thing. The blood bank has a shortage now, and they continue to have a shortage. And as the summer goes on and the potential impacts of Zika on our blood supplies, not only down south but on a national level, they have some very big concerns about being able to maintain that supply. So if you get the opportunity, feel free to stop in there. They're great people. They'll talk to you. They'll provide you great service. They give you food at the end. I mean, you can't get better than that.